So we have a young 15-year-old athlete here. He's had past nail surgery on both feet. His left's now successful, but his right has suffered a recurrence. So we've discussed the procedure that we're going to do. The patient wants a total nail avulsion, but for the purpose of this presentation, we're just going to talk through how you would do a wedge resection. We've drawn on the nail what it would look like, and it's clear to see that there would be little point in doing another bilateral wedge resection, which was the previous failed procedure. We've prepped the foot with iodine, and all the preliminary checks have been done. Consent's been obtained, and the possible complications of this procedure have been discussed. He's had 2 mils of local anesthetic, bupivacaine 3% plain, and we've checked that the foot is fully anesthetized. So without further ado, we will start. If at any time you feel pain, just tell me. But I think we're pretty good to go. So just for the purpose of training, we'll just briefly talk through a wedge resection. And the first stage is we separate at the eponychia. And then use an elevator gradually down the free edge of the nail at the hyponychium towards the eponychium. How are you doing? Everything all right? It's always worth noting that gentle tissue handling is always really beneficial with post-operative healing and also post-operative pain. It can reduce the post-operative pain that the patient may experience. Then we take some thwaite snippers, flat edge down, cutting edge on the top. Position the toe so it's comfortable. Then, if you elevate your arm, you can actually get under the eponychium, which is really helpful when you come to use your chisel blade. So you've got a chisel blade. You run along the course of where you've cut, and you just gently, with the chisel, go under the eponychium. And you wait for it to feel it give. Then you take your Spencer Wells forceps. Again, elevate your arm to try and get right under that eponychium. Grasp. Remove your fingers and you rotate towards the middle of the nail plate gradually. Use it as like a turning fork, and you gradually rotate to the middle line, and you get clear wedge resection. Again, for the purpose of the video, we're not going to apply phenol to this area because the procedure is a total, and the patient's giving consent for us to demonstrate the wedge resection before we do the actual full procedure. There has been some talk about bud size from Swab-It. These are Swab-Its. I've used Swab-Its for 15 years and find them a really very, very good product. There's some smaller bud sizes in the pack if you need them. I never use them. I always feel that this, as you can see, fits nicely into the wedge. And some podiatrists who question the bud size, it begs the question whether they actually are removing enough of the nail for a wedge resection. Moving not enough nail will mean that the outcome of the procedure, 3 or 4 years' time, might need to be done again. And I'll go into with the total procedure of how to use the Swab-It, but you can actually see there that the bud size for me isn't an issue. So now we're going to progress and do the full total nail avulsion. Again, position the toe that's comfortable for you and the patient. And if you move the elevator horizontally across, it means that you're handling the tissues very gently because you're not at risk of breaching the nail bed. So I move the elevator across, then I lift once I'm under the eponychium. And when you're completely separated, you can see there's no damage to the nail bed with the elevator. You take, again, your Spencer Wells. I go from corner to corner. I'll just make sure that's separated. Makes it easier. Get your elbow vertical, and what you need to do is to make sure that you get right in that corner. When you're under the eponychium, grasp and change your grip and rotate again to the midline of the nail. If we hadn't done the previous wedge resection, you can rotate to the middle, and then you go down the other side and rotate to the middle. Some people prefer just to split the nail in half. And you can see the nails come out completely fully. If you're in doubt at all, you can check with the back end of a Black's file. For any resistance, and it looks particularly fully clear. So, having removed the toenail, now we have to destroy the nail matrix. So to do that, we're using a Swab-It. I've used these for approximately 15 years and find them so easy to use and they're so safe. It contains 0.2 of a mil of phenol only. Because of the various 2 alerts you had, the one recent one, you want to use as little phenol as possible because of the vapor that is released from the chemical. So, this is a Class 2A medical device and the only product license to do this work currently. To use it, you have to keep the ampule vertical. You take the applicator and you can feel resistance as you gently push. You have to break that resistance to access the phenol. And then you remove the applicator backwards and forwards a few times so that the swab absorbs the phenol acid. Some people protect the surrounding tissues with petroleum jelly. I just tend to use a swab just in case I need it for any excess of phenol. Again, you need to just check all that eponychium has been separated, which it has. If you raise the Swab-It about 45 degrees and then rotate, because the phenol is in this end of the swab, and you can see the phenol coming out. Could you start and give me 1 minute? Now I'm ready. And you can use a little bit of pressure because you want to make sure that phenol is rubbed in each corner and across the base near the eponychium. This is where the growing matrix is. And these are the cells that we need to destroy so we don't get a regrowth. This procedure was first done by a chap called Bowl in 1945. And the suggestion from Bowl was 3 1-minute applications of 89% phenol. Thank you. There are lots of trials recently who've demonstrated, randomized controlled trials, that using 2 1-minute applications does not affect the outcome. Today we're going to use 3 1-minutes because this young man has had a couple of regrowths. So we really want to make sure he has the best chance of having a successful procedure. If you angle the Swab-It, you can see how it's pressed against the nail bed, that the phenol is released from the swab. If you don't rotate, a lot of the phenol will stay within the swab. You can use some abrasive action, which is recommended from the literature, because that helps to ensure that the phenol is absorbed into the nail matrix. Okay. And you can hear it break the seal. So this is the last minute. Just stop the timing for a minute. I'll just see if I can get a bit more phenol on there. Unless you want me to drop me another. Just want to be really, really give this the best chance of being successful. And you know where the phenol has gone because, as you all know, it blanches the tissues, and you can see a clear blanching effect. And you can see me rotating, and you might be able to see all this phenol coming out, which is good. But this rotation is key to the success of using this product. Okay, thank you very much. The next best thing is to remove the tourniquet before you do anything else, because that's where the less risk is, the most of the risk is leaving that on. And as you can see, you can then see if it's bleeding. So then there's another issue that can be contentious is, do you irrigate? Do you not? The idea of irrigation is it doesn't neutralize the phenol. It just ensures that there's no pockets of phenol left in each of the corners. With a total, I usually irrigate because the main contentious issue about irrigation is that you're spreading phenol across, but with a total, you're spreading it across both sides of the nail matrix anyway, so now we just arrest the bleeding, which is very minor. So you can see he's coagulated really quickly. So for today, we're going to use some Inodine gauze for the first dressing. Covered over with melanin, shiny side to the gauze, and then some swabs over the top. Have you got any me fixed? Hey, you got that? Yeah, thank you. So the first dressing has to be obviously quite large and thick, because when the patient goes in dependency, there is a small risk that you might get some minor bleeding. Also, when the patient leaves, there's always a risk that it could be knocked. Thank you. You don't want to touch dressings too quick because you will get some, I'll have a couple more in a minute. You will get some swelling because you've just put phenol, which is carbolic acid. And when you do some ingrown toenails, they might have some sort of mild infection. Right, I probably need 2 strips, one for there. And one for underneath. Yeah, please. Have you got the large tube gauze? Yeah. And I'll just have one more piece of Mefix, please. So we've given this patient advice on post-operative care during the consultation. We'll go through it with him again. I usually use 2 base as well, just in case. Oh, you've got them there. Well done. You're the same then. So we would advise this patient to get a limbo because he's had a phenolization, so healing will be anything from 6 to 8 weeks is expected as the norm. To have it redressed, depending on if there's seepage, within 3 to 5 days. And then either once weekly or twice weekly, depending on the amount of discharge caused by the phenol and what the wound looks like. Thank you.